Okay, penicillin allergy. We are going to. Okay. Uh, penicillin allergy. Okay. So we are going to talk about some of the allergies that we normally see in patients, and many a time it's expressed on the skin and mucous membrane. The question basically is that in this particular case, you can read the history where a person receives penicillin for pneumonia several years ago. So that's a typical sensitization phase. And then I presented last week with what appears to be an allergic reaction to the drug. And they initially thought this is a sinus infection. And they put him on oral penicillin, and then his eyelid become puffy, his abdomen is covered with itchy, nearly confluent hives, and then they want to give him a drug so they can soothe him down. And lab tests were showing to have elevated level of tryptase. If you remember, tryptase was an important mediator that was released to cause tissue death. And then again, the person has decreased C1 and C3, which are complement proteins. Okay? And then a skin test with penicillin was negative. So sometimes what may happen is that we don't really get a good picture, but the question that you have for this case is that which of the elements of this case suggest that this was caused by circulating IgG antibody drug complexes, because we're talking about type 2, rather than IgE antibody to penicillin. So what do you think in the previous history made you to think that this is a IgG mediated antigen antibody type 2 reaction as compared to type 1 that you normally would have seen? So you have like E different choices. How many of you think A? How many of you think A? Choice, raise your hand. B. One person thinks B. How many of you think C? Okay. How many of you think D? Only one. And E. E. Okay, let's see what the correct answer is. Yeah, because you can see from here as well. They're too smart. Okay, so that wasn't a good deal. The explanation for that is we would have thought immediate like an IgE, but firstly, he did not test positive to allergen, and secondly, the complement levels are decreased, because complement levels, when they decrease, we are thinking not for type 2. Right? And then again, you also saw it took a little bit of time for these symptoms to appear. So many times when you see the patient, especially in ER, it's a difficult scenario for you to figure out. But most of the time, the drug reactions actually come like this. You can see the drug reaction, the rashes on the skin. You know, these kind of a picture, erupts, rash erupts immediately. And that's basically the antigen-antibody complexes locating in different part of the skin or mucous membrane. That's a typical thing that you see. And then again, you saw this, again, patchy figure, swelling and so on and so forth. So I'm going to go quickly because some of the things I think I'm going to spend time because we already spent time. So type 2 hypersensitivity reaction, that's the important thing that you want to take in this part. The important thing is that occasional side effects for drugs if you give those drugs, hemolytic anemia, so your red blood cells are destroyed. Thrombocytopenia, where your platelets are destroyed. And the most common drug to give you that picture are penicillin, quinidine, and methyl dopa. So, and there are many more, but these are the commonest drugs that we normally see that present at type 2 hypersensitivity detection. So let's understand the concept behind it. Now, if you look at a penicillin structure, we had a beta-lactam ring, and there's a reactive bond. So you can see this is how you give penicillin to the person. And penicillin and other small molecules can modify human cells so they display foreign epitopes. So remember that your epitopes on red blood cell are your cell. But if these drugs are given, they modify that and change the picture. And then your own cells will come and start killing them. Right, so in this case, you can see that penicillin binds to bacterial transpeptidase and inactivates this. That's like a typical mechanism of action of how the drugs act, because you are giving these drugs and the person has infection. Now, at the same time, this is a positive effect where you want to stop the cell wall synthesis, and that's one of the actions of these type of drugs. But penicillin modifies protein on human erythrocytes. You can see from here, it kind of modifies that and attaches to it, and then your cell will come and will think that this is a foreign substance. So your erythrocytes basically are not normal, and then again, they will be considered as non-self, and you have hemolytic anemia. So you continuously lose your red blood cells. Now, how the sequence of event goes over here. So you can see from here, in this case, penicillin binds to that. So the penicillin modified red cell, which is now a different cell, acquires coating of complement component C3b, which is basically coming from the bacteria. Because there's a bacterial infection taking place. So you give a drug to fight a bacterial infection, and that bacterial infection basically releases C3b, which is an opsonin to go after the bacteria and opsonizes so that it's more palatable for phagocytosis. But the penicillin modifies the red cell, and the red cell basically is then phagocytosed by your macrophages because it is considered as non-self. Okay? And not only that, the macrophage will chew that up and present those peptides from penicillin protein conjugate to T cells. And then T cells basically will process those antigens as non-self, and then you will secrete, you'll have a plasma cell that will secrete penicillin-specific IgG, which binds to modified erythrocytes. So it kind of produces antibodies against your own cell and kill your cell. So that basically it's a penicillin protein conjugate which produces the anti-penicillin antibody. So that's what it is. So you can see the role over here. When we looked at the patient, C1, C3 was decreased because it was attached to the red blood cells. There's plenty of red blood cells. Okay, so you can see these events happen within the body when we talk of penicillin allergies. Okay. Again, same thing in a little bit different perspective. So you have binding of antibodies to penicillin modified red cells, you can see from there, and then it basically going to activate MAC, membrane attack complex. We talked in complement. That's one way. The other one is going to cause phagocytosis. Both ways, you lose red blood cells and you have anemia. That's why many a time when you give antibiotics, side effect is either anemia or loss of platelets, and so on and so forth, because these drugs sometimes go and attach your own surface epitopes of those cells and modify it. And in this case, you can see killing. And in this case, of course, the very immediate thing you would do is to stop the antibiotic at all. Okay, so we did talk about that earlier, the structure of ABO blood group antigens. Again, if you were to look at the structure per se, you can see from here, remember I said the typical situation in this case is that ABO antigen arise from family of glycolipids on the erythrocyte surface. So these are typical structures. You have a oligosaccharide. You can see from here, you have either a glucose, galactose, and acetylgalactosamine, galactase, and fructose. So these are the typical structures. And you can see one structure here and there will make a major difference. So if you look at probably all these chain over here, till over here is okay. But these two structures on the top basically are the ones that are giving you a different blood group altogether. So you have an O antigen, you have an A antigen, or you have B antigen. So this is what the structure, typical biochemical structure is. Little difference of one will change the whole sequence of that. And again, you can see from here, recipient and potential donor, anti-A and anti-B antibodies for O, and so on and so forth. I think we already did that, but this will give you an idea that what type of structure is there on your blood vessel and where are the things coming from. Why we are talking about that? Because transfusion reactions are considered type 2, typical type 2 hypersensitivity reactions. And again, this is a typical early response where there is a little antibody and excess of antigens, and it forms small immune complexes, and they basically are not easily going to fix complement, because if they fix complement, it's more problem, but they are not cleared from the circulation. That's another thing that you need to clear them out from the circulation. But if you look at the second one, which is intermediate stage, where the complexes are large, and they fix complement, and they are cleared from circulation. And then again, medium size are formed, and they are also cleared from circulation. But you can see from here that if you don't make good enough antibodies, you fight an antigen, but these basically would not be removed from your circulation. And what will happen? If they are not removed from circulation, they will basically go and attach themselves in the tissues and then initiate a typical inflammatory response. You see a typical inflammatory response, and then within hours, you will see all those complement proteins coming over here as well. And then depending upon wherever that deposition of antigen-antibody complex is taking place, in joints, arthritis, in kidneys, nephritis, you name it, and it's going to cause inflammation based upon whatever you see. If you look at these patients, for example, in type 2, as I just said, if it's intravenous vasculitis, meaning blood vessel, nephritis in renal glomeruli, and arthritis, if it's subcutaneous, you will see as a Arthur's reaction. If you inhale, it's called farmer's lung, and this is what you see typically. But that again is an overlap between type 2 and type 3, where the antigens are fixed and antigens are not fixed. Okay. Now, type 4, you will see again that the whole idea for type 4 initially is that this is cell-mediated. And CD4 T cells are the major players to begin with, because they initiate the cascade of cytokines. When you say cytokines, they are basically coming from CD4. And these are chemokines as well, gamma interferon, TNF, and IL-3, and granulocyte, macrophage, colony stimulating factor. So these are the typical cytokines which are released here. Okay? And if you look at the example for that, contact hypersensitivity, this is a typical feature that you will see, like a poison ivy. That's a typical picture that we normally see. So we have a first contact in terms of primary or sensitizing response, and then there's a second contact that comes over here, and this is the structure of the molecule that causes this. Okay. And as I said earlier, the whole idea for type 4 basically is that we need to fight the environmental antigens, and we want to react to them, and that's considered as a positive if it's under control, but will be negative in terms of if it gets out of control. Okay. All right. So one thing you must have realized by now that allergic reaction can lead to inflammation, right? Because when I said antigen-antibody complexes, they go in kidneys called nephritis. If they go in vessel called vasculitis. If they go in joints called arthritis, meaning itis mean inflammation. So there's an inflammatory cytokines. And what happens, what's the problem in inflammation? Why do we worry about inflammation? If, like, for example, you have inflammation of joints, what is the danger? What is the problem with inflammation? Why do we care? Inflammation can lead to cancer. Chronic inflammation. Okay, good. What else? Tissue damage. Like what? Any particular type of tissue damage? Necrosis. Okay. What else? You're right. What else? Why do we care?
It's pain.
Right. There's a pain. Arthritis, when we say rheumatoid arthritis, pain is a major issue because it's very painful. That's why we have those tons of drugs, analgesics available, and we're still fighting. Pain is one of the major issues when we have inflammation. Good. What else? Sorry? Did I miss something? Okay. If it's a, let me give you an example of pelvic inflammatory disease, PID. PID, so it's a pelvic inflammatory disease. So what do you think is special about that in terms of inflammation? It leads to sterility. Why? You're right, but why? Inflammation causes damage to those cells which are
in the, I guess,
peritoneum. Okay. Partially right. But tumors. Well, that's what she said. Chronic inflammation can lead to cancer. I think the most important thing that you have to keep in mind is whenever, yeah, want to say something? Whenever there's an inflammation, there's always a healing. And when healing takes place, there's always a fibrosis. Well, you said that PID leads to sterility. That's because if there is an inflammation in fallopian tubes, for example, so that will come with a healing. When it heals, it's replaced by fibrosis. And fibrosis will cause adhesions. So adhesions will basically then cause problems. So that's the major idea over here. You don't want inflammation because if you have inflammation, like a cut, the healing is going to be replaced by scar. What is corpus luteum? corpus luteum. I'm going to talk to Dr. Nawaz if he didn't teach you endocrinology. Corpus luteum.
That's the sac that you're talking about in reproductive testosterone.
Okay, listen, what happens is that corpus luteum, basically, remember that, when you talk of the estrogen progesterone production, that's taken over in the ovary, that's because it is replaced by corpus luteum after pregnancy. Right? So this means the egg that is released, if it is fertilized, so corpus luteum remains as a source of providing those hormones. If there is no fertilization of that egg, that corpus luteum is replaced by corpus albicans. And there is a fibrosis there. So what it means is that it's a part of, I think, reproductive endocrinology is that there's a fixed amount of cells in the ovary, like 30,000 cells in the ovary, and 1 or 2 are shed per cycle. And they are then replaced. There's a construction. Okay, they are replaced by that. So that means that if every monthly cycle, if they are replaced by corpus albicans, then time will come that the ovaries get totally fibrosed, and that will be the beginning of menopause. So the whole idea is that if the fibrosis, the function is lost. That's why we have some of the hormones over there, they are required to remove that fibrosis, because we want to have a inflammation healing without fibrosis. Does that make sense? Okay. What normally happens is that I wish if this was the case that every thing, especially for P1, is basically a foundational subject. If you understand that, you understand use of oral contraceptives. If you don't understand reproductive immunology or reproductive physiology, then you will struggle. Why are we giving estrogen? Why giving estrogen? Why all these things? Because you need to understand where is the source of the estrogen progesterone. So everything should ideally add on, right? Otherwise, if that's the intention, learn and forget, vomit, that's not, well, may benefit temporarily, but you will not form the basis for that. So you can see by many different diseases that we normally see, hundreds of them. That makes you wonder how can we remember all these diseases? Because if you know the pathology of diseases, you pretty much can know what the function will be compromised and what will be the result and how do we need to treat that. Right? If you do not, then it becomes very difficult. For example, in this case, you can see we talk of Hashimoto's thyroiditis. I'm pretty sure that you must have done it in thyroid. Okay, so what is Hashimoto's thyroiditis? No, what is the pathophysiology? What is going on? Pathophysiology. These are our pathophysiology. Hashimoto's thyroiditis. Hypothyroidism. I said pathophysiology. So if you understand pathophysiology, it will be easier for you. It's considered as an autoimmune. Yeah.
The antibodies bind to the thyroid and it activates the thyroid that keeps secreting.
Antibodies bind where? They have to bind somewhere. Yeah. Because remember that there is a thyroid stimulating hormone that's released from pituitary, and then it comes and binds to thyroid, and there are receptors over there. That's basically if they are blocked by autoimmune disease, that your receptors are taken as a self, so you will then have no action of thyroid stimulating hormone, right? So you basically will have less thyroid because the body will think that, it's like a negative feedback. But it doesn't know that the receptors are blocked by those antibodies that are taking care of that. But anyway, so you can see from here, many times in the diseases you will see inflammation and use of antibodies or anti-receptors to antibodies, and then again is a typical clinical picture that you look at the mechanism of disease, and then you look at the clinical pathological manifestations pretty much. So if you know the basic pathology, it will be easier for you to understand the clinical picture. It will be easier for you to know what drugs are required, because that will form you the basis for that. And you can see from here that Graves' disease, for example, is a hyperthyroidism, and you have an antibody-mediated stimulation of TSH receptors, and then pernicious anemia, and so on and so forth. So these are all the basic information in terms of antigen-antibody reactions that we normally see. Okay? So you can see these are examples of those where we have cell or tissue-specific antibody. That's what it is. And if you want to look at the immune complex-mediated diseases, SLE is common, polyarthritis nodosa, post-streptococcal glomerulitis, because this is something that I will also discuss again. Post-streptococcal glomerulonephritis. Remember when I said that when you have a streptococcal infection, then your body makes an antibodies to fight those bacteria, and these antibodies will go and also attach to many different places. One of the places is kidneys. Other places is heart valves. And then you have a big problem, and you have a rheumatic disease. So that's another thing that we need to talk about. But again, in this case, the human complex-mediated diseases are important. These are some of the diseases where you have T-cell mediated immunological diseases, where like type 4. So you can see from here, there's a list of diseases. In diabetes mellitus is there, that is considered as rheumatoid arthritis, MS, inflammatory bowel disease, Crohn's or ulcerative colitis. We have peripheral neuritis and autoimmune myocarditis. So these are some of the basic things that we normally see clinically. And then again, you will see each one of them basically has a human disease element, and there's a problem with the T cells. So there's a T cell problem that leads to these clinical disorders that we normally see. Okay, we talked about that. Okay, again, simple slide. You can see antigen antibody. They make a complex and get deposited, because if they get deposited, they are structures. They will attach somewhere, and they will either obstruct the lumen or initiate inflammatory response. Okay? Pretty much the same thing that we already discussed. This was something that you just told me, that we have a receptor, and the antibodies recognize that as a foreign. They attach to it, myasthenia gravis, where the acetylcholine levels will be decreased. So that's again the pathology over here. Okay. Typical tests that we normally do for antibody-mediated glomerulonephritis or any other thing. We take a tissue section, we stain them with antibody color, and then that's what you see in a typical fluorescence. Okay. Now, if you were to look at the serum levels of these particular patients, so what normally happens is that over a period of time, the antigen basically levels, you can see from here, keeps decreasing, whereas the immune complex levels basically rise up. So they form the antigen immune complexes, and then it comes down. So that's a typical story in terms of a diagnostic type for antigen or antibody. Okay, let's see. We talked about delayed hypersensitivity reaction. I don't want to spend my time on that. Okay. These are some of the characteristics for delayed type hypersensitivity. So you can see all the way from beginning to 24 hours to 4 weeks. And each one of them has a name. We've been talking about DTH, which is a type 4 hypersensitivity reaction that basically is over here. But if it happens within 24 hours, we call it Jones mode. If it happens at 48 hours contact, it happens later, it is a different story. So you can see from here, when it comes to clinic, it comes to diseases, then the basic information gets a little bit jumbled up. So you really need to do many more things that you pretty much are used to it. And then again, you can see the clinical appearance, you can see histological appearance, and you can see many a times where the antigen is coming from. In this case, nickel, rubber, poison ivy, these are some additional things that people have a delayed reaction to. Okay, pretty much the same. Some drug delivery slides. I think I'm not going to spend much time on that. Just one more slide. I wanted to show it to you for the drug delivery if I could. Okay, yeah, I think maybe this will be the final one. Again, you can see the players are the same. So you have all the same players that you've been listening about, the antigen presenting cell, the B cell, the T cell, and depending upon what cytokines they release, what are the effects of those cytokines, the drugs are basically there either to block the receptor, block the cytokine, or basically stop the activation of T cell or B cell, or block the class switching for antibodies. So these are some of the things that we normally do in terms of the structures that we have. And I think I'll just stop here because I wanted to give you half an hour to prepare